Okay. Good evening, friends. I am Dr. Abhasai Patankar, today's moderator for the CME. Today's CME is a part of a Down syndrome celebration, which we are doing as a World Down Syndrome Day, which is celebrated all over the world on 21st of March. We have decided that this Down Syndrome Day, World Down Syndrome Day, will keep one CME by which we all will come to know in depth about Down syndrome, because when we see a child of a Down syndrome, we are so used to see the child and we recognize in no time because of their smile and the characteristic facial features. It happens in our OPD practice that even our staffs also get trained to see the child, and the moment they spot, they come and tell us, it is everybody's experience that, sir, ह्याला Down syndrome आहे का? Is it a stigma? But I tell you, the parents of Down syndrome, it is not a stigma. They take it so lovingly and they try to do everything for that child. And the way they come in the OPD, as if that child is a very special child. I just, while preparing for this moderation, I came across one poem which I'll share with you. When I go for a walk, people look around at me. Will you will you hold my hand? They look around me. There is something wrong. Will you come to? Perhaps I'll put my earphones in and play my music extra loud. I'm going for a walk. What's wrong? Will you come to? Will you hold my hand? Definitely, we are going to hold your hand. We are a very gentle, kind pediatrician of IAP Raigad. We have hosted this CME on Down syndrome, and we have got special invite, basically special guest, Dr. Shruti Bajaj madam, who is going to talk about general aspects of Down syndrome, and we have got special guest, Dr. Archana Kadam madam. She is going to talk about developmental concerns about Down syndrome. We have got a very senior pediatrician, Dr. Niyaman Mohinty sir, Dr. Chandrasekhar Dabadkar sir, Dr. Chitra Kulkarni madam, and Sunita Ingre madam. At the same time, Dr. Sampath Sasani sir, Dr. Bharne sir, Dr. Nilima Mandarkar madam, Dr. Dhananjay, Dr. Vaswani madam, and our own Dr. Sunil is also there, and Neha Singh madam is also there. If I have forgotten anybody's name, Dr. Parvez is also there. Our great president, Dr. Pramod Wankhede. This is the first CME on Down syndrome. I think it is happening at Raigad IAP platform. I request Dr. Pramod Wankhede to just say his few words regarding the CME.
Yes, thank you, Abba. Thank you very much, and thank you for your poem. You have shared it. Really touching. So, dear friends and respected seniors, and today's expert, Dr. Archana Kadam madam and Dr. Shruti Bajaj madam, our seniors, Dr. Dabadkar sir, Dr. Mohanty sir, Dr. Mohite, Dr. Sasane sir. Today, we are celebrating Down Syndrome Day, and I extend my wishes on this occasion. Dear friends, actually, every disease have a probable genetic basis. It is proved that. So therefore, we must learn about diagnosis and management of common genetic disorder. Most of them are amenable to therapy. They respond to therapy, and most of are very fatal. But that can be prevented at genetic level only. We must have knowledge about it. That is mandatory. So genetic disorder can be chromosomal disorder, maybe single gene disorder, polygenic disorder, mitochondrial disorder, or else, etc. So Down syndrome is the most common chromosomal anomaly at birth, and in respect of that, we have a very eminent speaker, very stalwart speaker, Dr. Archana Kadam ma'am is a developmental pediatrician at TM. She will be talking on developmental aspect, and Dr. Shruti Bajaj ma'am from SRCC Mumbai will be talking on clinical aspects. So let us learn more about the disease so that we can help our patient. Over to Dr. Abhasai. Thank you very much.
Yeah, thank you, Pramod, for nice elaboration. It is called that the difference between ordinary and extraordinary is just that little extra. We have got extraordinary speaker. Uddhav mute kar. Uddhav mute kar.
Just Abba.
Yeah.
Abba, I request Vishal to mute all except speakers and moderator.
Okay. It is said that the difference between the ordinary and extraordinary is just that little extra. To put more light on Down syndrome, we have got Dr. Shruti Bajaj, madam. I'll start. Basically, I have got an introduction list about her. She is MD Pediatrics and Fellowship in Clinical Genetics at KM Hospital. She has additional training and observership at Kasturba Hospital, Manipal, and in Switzerland. Madam is ex-associate professor of pediatrics at Genetic Clinic KM Hospital, Mumbai. Madam has got clinical interest in pediatric and reproductive genetics, dysmorphology, inborn error of metabolism, and skeletal dysplasia. Madam has many publications, 27 articles in index national and international journals. Madam has written 6 chapters on inborn error of metabolism, approach to neonatal encephalopathy, neurofibromatosis, Marfan syndrome, achondroplasia, vitamin D resistant rickets. Madam is also received multiple awards for poster and podium presentations. Madam is a founder and director of her own, the Pearl Gym Clinic at Mumbai. Presently, she is attached to SRCC Children's Hospital, Haji Ali. And Madam is founder and scientific advisor for Support Group of Down Syndrome, PEHEL. What is it, PEHEL, Madam? You elaborate on it. With this short introduction, I request Dr. Shruti Bajaj to kindly start the presentation.
Thank you so much, sir, for that very kind introduction. And it's my debut today at IAP Raigad. So it's my honor. And I would first at the outset like to thank all the seniors and IAP Raigad to have me over today. Indeed, Down syndrome and PEHEL is a topic very close to my heart, and it's my pleasure to share my reflections on the same. I hope my screen is visible, and with the permission of the others, I'll start my talk.
Yeah, please start, madam.
Yeah. Well, so I think Dr. Abba Sahib sir rightly said few minutes back, Down syndrome is something which even a commoner, even a non-medico can pick up, playing in the garden, walking in the mall. So I think we are beyond a point where diagnosing Down is a challenge. I think now we are in a stage and a phase where we have to move beyond the label. What after the diagnosis? How do we improve their lives? How do we maximize their potential? And so I'm going to try and shed some light today on, of course, the clinical features that's been told to me, but with the kind permission of Dr. Wankhede sir, I thought it would be an opportunity for me to share 10 common myths which I have encountered even among medical professionals, even amongst pediatricians regarding Down syndrome. I promised to keep the talk within my stipulated time of half an hour. And of course, this would be followed by a quick glimpse of the clinical features, which a lot of us are oriented to, but how do we translate our knowledge of these clinical features to a practical surveillance program? So I'll just come to the first part of my talk. Yes, we agree Down syndrome is one of the most commonest genetic causes of intellectual disability globally. You would be surprised that only in India, over 20,000 individuals of Down syndrome babies are born every year. And this was as per a paper in 2017. So these are not figures pre-screening era. Despite the easy availability of aneuploidy screening tools, of course, given the limitations, and we will discuss the caveats, over 20,000 individuals of Down syndrome being born in India alone. And although we are sensitized as a community of pediatricians overall, there is a lack of medically backed support groups for these individuals. Often, the commonest grievance which parents will share with us is that they don't have a single portal for authentic information other than Google. So how do we understand, doctor, what are my child's problems? How do I deal with it? Right from special schooling to making a will for my special child to career choice, Who will help me out? And it is at such points that the humble realization dawns upon us that dispelling the wrong ideas and clearing the myths can often be such an important part in the life of these parents, other than, of course, guiding them about the practical aspects. So first, often we have seen parents who come telling that I'm so scared because I've had one child of Down syndrome and I don't want to plan another, because, you know, it's a genetic condition and genetic conditions run in the family. So where we know that if we were to take all the different molecular types of Down syndrome, most of them are sporadic, few due to balance translocation. Even within them, most of them are, sporadically occurring, very few inherited. So effectively, the risk of recurrence in a lady who has had one child of Down syndrome, of course, it depends on what type of Down syndrome is it. Is it a complete trisomy? Is it a translocation? But the effective risk of recurrence, if it is in most of the scenarios, would be around 1 to 2%. Of course, it would be wrong to reassure the parents only without looking at the karyotype, but it is also important to remove their guilt and blame that I ate something, I went out in the eclipse, there was an evil eye. Often removing these guilt and blame can play a very important bond in part in fostering a healthy bond between the parent and the child. This is a very quick recce. I'm sure we all are aware of this. So in the non-disjunction types, as well as in the mosaic types, it's not much, just 1% higher than the general population. Of course, based on the type of the translocation, it's usually between 3 to 15% in very rare scenarios. So in all these years, after seeing so many children with Downs, I've seen just one case of a translocation 21-21, in which case the risk of recurrence is actually 100%. So again, it stresses on the importance of us looking at the karyotype of the child with Down syndrome. Again, one of the common myths is that most children with Down syndrome are born to older mothers. Here, I would like to draw your attention. Although this is a younger age group, you see the fertility in this younger age group is much more. So effectively, and I'm sure we all see this in our practice too, you will see young mothers with Down syndrome too. And because of their high fertility, in fact, they are a high risk group for Down syndrome. And often there is a misconception that we need to offer aneuploidy screening tools only to the mothers above 35 years of age. Well, that's not the case. You should be offering it to all the pregnant ladies. And I think if there is one take-home message which I would want the esteemed audience to take home today, I think we need to move ahead of dual and quadruple marker. And it's not just me advocating it. American College of Obstetricians and Gynecologists have universally, they have a hashtag NIPT for all. What is this NIPT? NIPT is non-invasive prenatal screening. Essentially, even that relies on a blood test the way dual and quadruple marker does. However, you see this table that while dual and quadruple marker can miss nearly 13 to 18% of the cases of Down syndrome, NIPT has got a very high negative predictive value, quite like the CT angio that Dr. Abasa was alluding to a few minutes back. Of course, you need to remember that they're all screening tools, and if it is positive, you do need to back it up with the confirmation. NIPT essentially looks at the circulating DNA within the mother circulation. So the child's DNA is circulating within the mother circulation. This DNA is extracted. When the mother's blood is taken, the fetal DNA is extracted out, and through various methods, it is seen whether there are 3 copies of chromosome 21 are present or not. This is what non-invasive prenatal test is. Be it your friends, relatives, neighbors, patients, children's mother, please advocate NIPT for all. This is the need of the hour, because often we have a support group called as PEHL, and there are so many parents there who you will listen to the story. We did dual marker, we did quadruple marker. Doctor, how come we have a child with Down syndrome? Simply because the sensitivity of those tests is not great enough. Well, the third myth is that children with Down syndrome have severe cognitive delays. While the truth is that most people with Down syndrome will have cognitive delays, but only of a mild to moderate type. They can fully participate in public events, in educational programs. She's Aditi Verma, an entrepreneur, hotel owner, cafe owner in Navi Mumbai. She had visited one of our Down syndrome programs. And well, yes, she may not be as intellectually advanced as maybe the hotel owner next to her, but she's running a full-fledged business on her own. So even the intellectual disability that they have is of a mild to moderate type usually. Again, one of the other myths is that most people with Down syndrome are institutionalized. That's not the case. They can live at homes with their families, and these are all pictures of Indian children, pictures of children within PEHEL. PEHEL is our support group with Down syndrome where we have different families. You can see this girl, and this is shared with the permission of the parents. They want the world to know that, look here, our children can do everything. This is a girl helping her mother to do the shopping, attending live music concert, taking part in a marathon. Well, what is it that they cannot do? Again, adults with Down syndrome are unemployable is an idea of the past. There are many NGOs. This is just to give an example. MAN is one of them. MAN, it is an NGO that helps in the employment of all these special individuals. And in fact, nowadays there are businesses that are seeking individuals with Down syndrome because of their friendly demeanor, trainable nature, if at all a cognitive delay that's only mild. And so we see that the times are changing. Other than Aditi Verma, for those who have seen this web series, Never Have I Ever, she's an actress. She does have Down syndrome, and she's an actress in this web series. This is a girl with Down syndrome who's an air hostess in an Egyptian Airlines. This was, of course, Aditi Verma at one of our events. Again, this is assumption that a lot of people have that, and maybe partly it is true that there isn't a lot of community support. Often parents do complain that, doctor, we get a diagnosis, but what after that? Well, there are support groups across the society. PEHEL, I always say fondly, PEHEL, after my two daughters, PEHEL is my third daughter. PEHEL is a full form, stands for Parent and Expert Forum for Health and Excellence in Life. We complete 4 years this year when myself and Dr. Anjali Gokarna, madam from Vasai, had founded PEHEL. It is a support group for the parents, by the parents, and it belongs to the parents. We have a very active parent support group which help us to conduct a lot of activities. We screened 41 children in an extensive health camp for Down syndrome. We keep 3 monthly talks by experts from neurology, orthopedics, ENT, OBGY, career counselors. And of course, we keep a lot of activities from picnics to, to kind of foster bonding between families. So there are support groups. I think we need to help these family outreach to them. Of course, they do not need segregated programs. Dr. Kadam, madam, would be speaking after me. She would be alluding on inclusive education, I'm sure. So these children can be integrated into normal schooling. They can have relationships in marriage, in marriages too. In fact, we have a 34-year-old girl from Pune who's a member of PEHEL, and she is looking for a appropriate match. They also have feelings and they too like to settle down. Again, it's not true that children with Down syndrome are always happy. I always tell the parents, although they may be happier than others, they are friendly, they too have a range of feelings. In fact, it's also noteworthy that children with Down syndrome are also more prone than normal children to autism, ADHD, which is not all that happy-go-lucky the way we imagine a child of Down syndrome to be. So you need to give them the whole range of emotions and human behavior, which we all have a right upon. And of course, one of the important myths is that individuals with Down syndrome have a limited lifespan. Not so with the current level of medical care, where they can easily live up to 60 years of age. And so, yeah, I'm going to very quickly, I know I've taken 10 minutes on this, but I thought it was very important that we address to these common myths, which maybe our parents or common general public, or sometimes we ourselves as doctors may be harboring few of them. Well, I don't think it's difficult to miss a child with Down syndrome in the OPD. But what beyond that? I often say that, Down syndrome is like the tip of the iceberg. There is so much hidden and unappreciated in genetic disorders. Down syndrome at least is fortunate that these children get a diagnosis at least, unlike so many other genetic disorders where families run without a diagnosis for years sometimes. But I think if we are lucky enough to diagnose, we have to then start looking beyond the label. We have to give the child a good quality of life. And based on these clinical features, we're going to try and understand in the part 2 today, what are the clinical features? And so how should I plan the surveillance? Of course, this is a nice summary table of all the clinical features and the percentages in which these problems are seen. You can see that nearly 3/4 of these children will have hearing problems. Vision problems are again common, right from myopia to having refraction errors, cataracts, obstructive sleep apnea. I am going to allude on a few of these, which I feel the awareness amongst pediatricians may be not as common as the others. I'm going to touch upon a few of them. Otitis media, congenital heart disease, hypotonchia. So we often see these parents, I often tell them, please don't give them any tonics, nothing, wait, be patient. These children, 1/4 of them will have delayed dental eruption. GI atresia often requiring neonatal surgeries, thyroid diseases, seizures, hematological problems, celiac disease, atlantoaxial instability, autism, as I said, and of course, Hirschsprung disease. So I always, in fact, this is one of the diagrams that we always draw to these families and say that, look here, this is your child. This is a beautiful child. It's like a sapling. And like any other tree, this tree is going to require gardeners to take care. The only difference is that there are going to be many gardeners taking care of this beautiful tree. So what are these various branches and manifestations that we need to look for? So again, intellectual disability, visual hearing, malformations. What is important is that those shaded in red are fairly reversible if detected early. Now, this is where the important part, I would say the take-home message, part 2. Often we see files of children with Down syndrome where a clinician has diagnosed around 5 years back or during infancy, but nothing beyond that, either because of parental lack of enthusiasm or because it's just that a label has been put. We need to know that a lot of concerns with Down syndrome can be ongoing, So even if you have documented one normal thyroid function, there can be ongoing autoimmune thyroiditis complaints. There can be ongoing issues of
मोहिते सर
atlantoaxillation. And
म्यूट
so
करता मोहिते सर म्यूट करता
that a surveillance. In the surveillance, you look and review for new clinical symptoms. You look for annual ophthalmic and hearing checkup, annual blood checkup, review the scholastic performance, growth in puberty, look for the vital signs, and of course, every time counsel about the next pregnancy. If we feel that the surveillance is poor only in India, that's not the case. I think we can take some heart over here. This was a study which was published from in the American Journal of Intellectual Development and Disabilities, where you can see that even in their population, something as common as hearing, vision, and IQ testing and thyroid was also not done in 100% of the cases. And even in Chicago Hospital, Children's Hospital, only 1/3 of the children actually received anticipatory care for spine problem and sexuality. So yes, it is a need of the hour. We all need to join hands together. I'm going to very quickly take through some parts. Of course, we all are aware about anemia, congenital heart diseases. Celiac disease, I would want to spend a minute. Amongst the common genetic disorders, Down syndrome, Turner syndrome, and Williams syndrome have markedly increased risk of celiac disease. And you really cannot pick it up unless you're plotting the growth chart on special Down syndrome charts. If you feel that the child is faltering even on a Down syndrome chart, it's important to look for, of course, few of the factors that I just said, or underlying anemia, congenital heart disease. One easily correctable factor is celiac disease. We know celiac disease is due to the gluten sensitivity, can have myriad manifestations, right from mouth ulcers, tooth erosions, to skin manifestations, bloating, diarrhea, constipation, not gaining weight, refractory anemia, even manifesting with behavioral and developmental problems. So I think we should keep a very low threshold. In fact, in my OPDs, I screen every child about 2 years for celiac disease, although this is nowhere in the guidelines. Given the easy treatability, non-invasive nature of trying to diagnose it, I think we should have a low threshold to pick it up. Again, obstructive sleep apnea, I'm sure we all are aware of how it has its outreach on multiple levels of functioning, right from growth to behavior, hypertension, learning, schooling, memory, even metabolic concerns and mood disorders. Well, these sleep studies are now easily available in Mumbai. In fact, we had conducted a subsidized sleep study on a large cohort of our PEHL members. And we found that, majority of them, the study could be conducted only in half of them. The remaining half were not cooperative. But in those that it could be conducted, we found that there was an underlying OSE component in the older children where they could not sleep supine, they had to sleep propped up. And it was so advanced that, it had kind of gained its roots right in multiple systems like the cogwheel that I showed few slides away. Of course, we need to keep a check on thyroid because we know that an underlying hypothyroidism can augment the intellectual disability. And we need to remember that we need to look at thyroid every year. In fact, in children less than 3 years, this should be done even more frequently, 4 to 6 monthly. So this is to just summarize what are the parameters that we should be looking for: growth, cardiac events, cardiac evaluation, hearing, ophthalmic checkup, thyroid, monitoring for celiac disease. CBC should again be checked annually. I will be touching upon how it is no longer necessary to do X-rays for atlantoaxial dislocation. As per the AAP guidelines, we can take an annual questionnaire on the red flags for atlantoaxial dislocation, which I will come to shortly. Ideally, polysomnography and pulse oximetry should be done once, at least lesser than 4 years of age. Practically, I can tell you it's possible in these children only after 4 years. Before that, they are very uncooperative. So at least between 4 to 7 years, we should try to document one polysomnography. So this is now coming to the last few slides. I will just try to run in the key where the lavender color says you should do it once, and yellow means you should do it if it is not done prior and the child visits to you late, and green one is repeated as per the intervals. This is taken from Up2Date. It is available to all of you. You can check it from that, and this is the publication from which I have derived it. So yes, we should, however evident this diagnosis of Down syndrome may be, please document it by karyotype. I have seen cases of Down syndrome mimic in terms of Smith-Magenis syndrome, in terms of Zellweger syndrome, where you may think that this is Down syndrome. Of course, I'm not trying, it's not that we would be making a mistake in diagnosing Downs, but sometimes a mild Downs and other genetic errors could overlap. It's always better to document the diagnosis. Of course, I even told that the type of the karyotype can help to counsel about the risk of recurrence. Echocardiogram, eye checkup. Echocardiogram needs to be done once and then repeated only as per the need. Eye checkup, of course, more frequent, twice initially in the first year and then annually. Same goes with hearing. Hemoglobin and TSH, thyroid, this should be done regularly, even later on, even if it is documented to be normal. Now, this is what I was telling. If the myopathic signs and symptoms are there, only then do we obtain the 6 X-rays, that is X-rays, cervical spine and flexion, extension neutral, open mouth, open mouth, AP, and the base skull view. In such a case, you need to tell the parents what are the red flags, and that is change in a gait, change in the use of arms or hands, change in bowel bladder function, neck pain, head tilt, torticollis, or new onset weakness. These are the red flags for a atlantoaxial weakness, which even in the study in Chicago, only 15% of the families with Down syndrome were aware that these are the risk factors for atlantoaxial dislocation. So I think it's not very difficult to kind of run it through in the OPD. Again, hearing analysis should be done annually in whatever way. Once the child is older, you can do it through peripheral audiograms. Ophthalmologist, I have told, celiac disease should be done at least once after 5 years of age. OT, PT, and speech therapy, of course. And this is just to give the rest of the summary. And this was how we celebrated Down Syndrome Day yesterday in association with IAP Mumbai branch, where we had called in a storyteller to, she weaved in wonderful stories of encouragement for the parents as well as the children with Down syndrome. And I think
Dr. Sachin, kindly mute yourself.
I think one thought which I always love to share with these families is, why do you want to blend in when you can stand out? Be proud, you're beautiful, you're Down syndrome. That does not make you any separate from us. We also have limitations, good, bad, ugly. I think we should all, as a fraternity of doctors and human beings, celebrate the differences rather than making them stand out. And I thank IAP Raigad for beautiful events like this, which really, will go a long distance in changing our perspective towards these families. I would be very happy to ever be in touch, in contact with any of you all. These are my contact details. And with that, I think I have finished just in time. Thank you so much for your patient listening.
Thank you, Shruti Bajaj, madam. While listening, we could able to guess that how passionate you are towards Down syndrome babies. And really congratulate you for your venture, Pahel, social activity you are getting, we are doing it. There is only one small thing. You have said that Dr. Anjali Gokan madam is with you. She is at Vasai, I think. How do you coordinate to run this venture?
So this is not a stay in place at Vasai. It's not that children stay there. So any parent across the city, across the country, we just have a WhatsApp group where we drive important content, because we had a website which we had to stop because we didn't have funds. We ran out of hand to mouth. So we just run a WhatsApp group where we help families understand how to avail of Niramaya insurance, unique disability ID. And I am at Malad. I do go to Ankur Hospital once a month. Vasai and Anjali Gokarna madam are very close to me. Madam has been very generous in giving her entire top floor for our Pahel office work. We keep our regular events over there. And I think when there is an intention, no distance is long enough, sir.
And do you, if we have got babies of Down syndrome, shall we refer to you to your group so that they will be benefited from multidisciplinary approach?
Yes, sir. So this group is entirely free of cost. There's only one inclusion criteria. It should be through a recommended person so that we don't get spammers in the group, basically. So anyone, I will, if you want, share, whenever you have a child, you have to just share the number. They don't even have to come and meet. They will get added to the group, sir. And I would want to add, this is a very neutral thing. It's a group where out of 100 people, 95 are parents. There are 2 to 3 doctors, and our whole effort is to wean the parents of us. Let them take the reign. Let them run the group. Let them be in charge. And that is what is happening as the years are passing.
Madam, excellent presentation. You have cleared our myths. At the same time, you have provided us the platform by which we can direct our Down syndrome babies to you so that they can be taken care very properly. Thank you. Be around, madam, because there is going to be question and answer session at the end. We are going to move to our second lecture, which is by Dr. Archana Kadam madam. Archana Kadam madam has done her MD and DNB from BJ Medical College and KM Hospital, Pune. She is practicing developmental and behavior pediatrics in Pune since 2004. Madam is very senior in that field. She has basically trained in Australia and she has come back and she is the authority in autism. Madam also, I have got very good family relations with her. It is always opportunity to listen to her. She has got very crystal clear concept about all the things what she talks. Over to madam.
Good evening, sir. Thank you for the kind introduction. Is my screen visible?
Yeah.
I will slide show. Take a minute. Oh, 1 minute. I'm not able to
Be comfortable, madam. No problem. Take your own time. No problem.
No, I'm not able to find the icon for the slideshow.
Ma'am, the lower right panel, lower
yes.
right.
Right.
Lower right, yes.
Got
yes.
it, got it. Thank you. Thank you.
Please continue.
Yes. Good evening, everyone. At the outset, on the occasion of World Down Syndrome Day, I'd like to thank IAP Raigad for giving me an opportunity to talk on an overview of developmental issues in Down syndrome. Dr. Shruti ma'am has set the perfect stage for me to talk on this. Now, as ma'am rightly said, Down syndrome is the commonest chromosomal abnormality that we encounter in our clinical practice, and 80% of mothers of children are less than 34. So, as you rightly cleared the myth that most mothers of children with Down syndrome are young mothers. We see children of Down syndrome all over the world. So there is no association with socioeconomic strata or geographic location. Contrary to the previous belief, previously we would consider children with Down syndrome as a homogeneous group. So we would say that children would have intellectual disability, and we talk about the characteristic phenotype manifestations that they have. Nowadays, with the advance in cognitive research and brain research, we know that the group of Down syndrome is a heterogeneous group. So you can have a whole range of manifestations. You can have children who might have moderate intellectual disability, or you can have a child who's borderline or even intellectually average. Similarly, the other developmental difficulties, the phenotype manifestations vary. So every child within the spectrum of Down syndrome is unique. It's important to start work early, because the earlier we work, the better functional outcomes we tend to have. Now, this madam has already cleared. We know that 95% of children will have 3 copies of the chromosome number 21, that is trisomy 21. 3 to 4% have unbalanced translocation, the commonest one being Robertsonian translocation, and 1 to 2% may have mosaicism. Means at the time of cell division, some cells might have 3 copies of chromosome 21 and some of them may not have it. Depending upon the number of cells that have it, we classify the percentage of mosaicism. It's important to remember that these 3 different types, you cannot differentiate it clinically when you see the child. Now, the medical issues madam has already covered, so I wouldn't go too much into this. When we deal with a child in the newborn period, what are the common difficulties that children could have? The first most common one in the newborn period is hypotonia. The child could also have feeding difficulties related to the low tone. So establishment of breastfeeding might be an issue. They could have congenital anomalies like duodenal atresia, jaundice. The common screens that we should do on all children in the newborn period is to do a 2D echo, because as ma'am said, 47% children are likely to have a cardiac problem. An eye check, a hearing screen, a thyroid, and a hemogram as a baseline in the newborn period. Coming to developmental issues. Now, as I said, it's a heterogeneous group. So every child is different. Generally, as a developmental pediatrician, children come into us around between 3 to 6 months of age. And the whole job of a developmental pediatrician is to help identify, screen for developmental problems, and intervene early. Some of the common developmental issues that we see is global developmental delay. Language delays are also common. Mostly expressive language delays are more common. Motor delays, behavior issues, some of them being ADHD and autism. We will be talking about all these in detail. Now, generally, children with Down syndrome are the high-risk group. These are the children who need a high-risk follow-up for development. So developmental screening needs to be done initially every 3 monthly for a year, and then every 6 monthly later on. If we look at developmental milestones, this is not hard and fast, but this is just a general guideline for us. So if a neurotypical child is sitting by 7 months, we would expect as an average, a child with Down syndrome to sit around 11. However, some can sit later, some can sit earlier. If a neurotypical child creeps at 9, a Down syndrome child may creep at 17 months. If a neurotypical child walks at 13 months, generally a Down syndrome child takes twice the time to do it, but we do have children who can walk earlier than that. Babbling in a child with Down syndrome is at 15 months, and the first word is generally at 18 months, but every child is different. So the first difficulty that we generally encounter when the child comes into us at the first visit at 3 to 6 months is generally a tone abnormality. There might be delayed motor milestones. There might be generally there is hypotonia. Very few cases where you might have tone fluctuation. So what is our job at that stage? One is to counsel the parents. Two is to initiate therapy. At this age, what we would do is start off with physiotherapy. We would give the parents a home program to foster correct strategies for active participation in movement for the child. And we would keep a regular follow-up for ongoing needs. Because at a later age, say when the child starts to learn to stand, the child might need an orthosis to have a correct posture to stand. So needs of the child unfold over a period of time, which is why a neuromotor follow-up is very essential. As I said before, generally children with Down syndrome take twice the time that a neurotypical child would take. The more severe the hypotonia, probably the child will take slightly longer. Also, sometimes if the child has a cardiac problem or a surgery which has prevented having correct physiotherapy or opportunities for movement, the child might walk a little later. So having a neuromotor assessment, physiotherapy, home program becomes essential. So at a slightly older age, when children learn to use their hands, sometimes they may need help with self skills, with pre-writing activities, with dressing self, and there comes the role of occupational therapy. Now coming to cognition. In children with Down syndrome, you see a huge spectrum. So you may have 80% of children who may have moderate intellectual disability. Some may have severe, but you have children with borderline intelligence and some in the normal range. So generally, when children come into us and we are doing a routine screen, generally around 18 months is the time where we would do a developmental assessment on the child. The common test that we would do would be either a DASI or a Bailey scale, where we play with the child and assess how the child is doing in different domains of development. We identify the child's strengths and weaknesses and thereby start an intervention program or some therapies if they are needed. Now, it's not hard and fast as to what age IQ is predictive. The DQ is definitely not predictive of how the child is doing. It just tells us our strengths and weaknesses, teaches us to work with the child and keep a follow-up. Generally, it is the IQ around 8 years, which may be predictive of the child's adult IQ. Now, sometimes if we have children who have borderline intellect, they're doing really well at the younger age, the better our program is, that would manifest as a strength of the child. When we do an IQ on the child at a later age, what are these children good at? Visual spatial processing and perception. So they are visually very strong. They're very strong with pictures, which is why as a strategy to teach them and foster communication, we do use a lot of visuals. At a later age, visual long-term memory sometimes is an area of difficulty. Now, in terms of prognosis, how does a child do? Generally, if a child is from an upper socioeconomic class, the child doesn't have autism, the child doesn't have epilepsy, the child's cognitive outcomes are better. This is as per a study. So probably higher socioeconomic class, we have picked up the child early, we have had our early intervention into place. That's why our child is doing well. No correlation of sleep apnea with outcomes on IQ. Congenital heart disease, the cognition may be spared, but languages in most children are inward. So clinical message here, do a high risk follow-up, keep a screen, do a developmental assessment at 18 months, and introduce intervention and therapies as needed. Every child's need for therapy is different. So investigations, I think Madam has already covered. In our intervention program, the most important thing is to give the parents a stimulation program. If the parents are positive and sensitive, the child is really going to do well. So what is the role of a person being a developmental pediatrician? We deal with the child generally comes into us really early. So our job is to start intervention, to counsel the parents, to do regular screens, to do a developmental assessment as needed, to address comorbid problems which may evolve over a period of time. At a later age, sometimes if there are attention issues, children might need medication. Our job also involves guiding parents for school. So our job is an ongoing job and it continues till adolescence. Now coming to Down syndrome and hearing, 2/3 of children with Down syndrome may have hearing difficulties. The common difficulty is hearing loss. Conductive hearing loss, otitis media with effusion is common because of the narrow ear canal and the craniofacial structure. Sometimes sensory neural hearing losses may also be there. So OAE at birth, yes, but a BERA also before 6 months. So if at all there is a sensory neural loss, we can start intervention early and the child will have optimal language outcomes. Hearing screens need to continue even after 2 years, every 5 yearly, because hearing issues can evolve over a period of time as well. If the child hears well, the child follows instructions well, and the overall language outcome of the child will be better. Coming to language, we know that in Down syndrome, many children have good receptive language. Where they lack is expressive language. Say, for example, you do a Bailey's on a child at 2 years, and you see the child is cognitively at 18 months. So that's his developmental age. Language, receptive language, understanding of language is generally at 18 months. Expressive language with words is less than a year. So they understand language better than how they express it. But when we express language, we also express with gestures. And if we see our children with Down syndrome, they imitate gestures beautifully. So 24-month-old child's gestures will be at 18 months if his cognitive age is at 18 months. Expressive word use may be delayed. This may be related to auditory attention. And that is the reason why we would start a program early to foster communication and speech therapy. Sometimes we advocate these children starting schools or daycares to foster the communication. Verbal short-term memory is a difficulty, which may also contribute to expressive language difficulties. Syntax, how a child organizes words in a sentence, may sometimes also be affected. Speech clarity issues may also be there. These may be related to tone issues. What are the strengths of our children with Down syndrome? They can tell stories. A lot of them can tell stories beautifully and stay on a topic. If the parents are sensitive, if they are responsive, and if there is good therapy in place, there are good language outcomes. So the clinical message here is do a DQ at between 18 months to 24 months and give a stimulation program and start therapy as needed. Not every child needs it, but monitor so that you can pick it up in time. Coming to eye difficulties, children with Down syndrome are known to have cataracts. They might have nystagmus, which generally reduces as they become older. They may have refractory errors. The visual acuity difficulties are more for near vision than for distant vision. So if a child is not able to see well, automatically the child's ability to sit in a class, copy from the board, the executive functioning, social adaptive functioning or self skills are going to be affected, which is why routinely screen for eye problems and identify them early and intervene. Coming to social skills, now it's a huge spectrum. So you might have children with Down syndrome who are very social, very friendly, and these are the children who as adults will have lower aggression and antisocial behaviors compared to other disabilities. But variability, 5 to 7% children might have social difficulties enough to fulfill a diagnosis of autism spectrum. So if we look at a child who has Down syndrome and comorbid ASD, how would we pick these children up? When we are doing a routine screening of our children, we would find that these are children who have difficulties in communication, difficulties in social interaction, in eye contact, in giving, showing things, joint attention. These are children who are using behavior for need. They are pulling the parents to what the child, whatever he wants. So there is a social communication difficulty in gesture imitation is a pointer. If a child is not using gestures for communication, if he has sensory issues, if his imitation in play is hampered, this is a child who has red flags for a comorbid diagnosis of Down syndrome and ASD. So we would screen the child early. Why is it important to pick up a child who has comorbid Down syndrome and ASD? Because our treatment strategies change. Children who have ASD along with Down syndrome may need behavior therapies to foster correct behaviors. They may need sensory integration in case there are sensory processing difficulties. So the therapies change, the intervention changes, the school placement also becomes an issue at a later age. So identify children early and we can have the correct program in place. Coming to ADHD and Down syndrome, the prevalence of ADHD in children with Down syndrome is quite high, around 43%. So it's not true that a child who has moderate intellectual disability has ADHD. No, you can have a child who is cognitively able, borderline intelligence. His or her only difficulty is attention to task. So these are children who might have hyperactivity, restlessness, impulsivity, tantrums, and this difficulty is not just in one setting, not just at home, but when the child is taken out in a social scenario, goes for a birthday, the hyperactivity may interfere with the child's social behavior. The hyperactivity may interfere with the child's ability to be integrated in class. That is significant hyperactivity. In a child who has ADHD and Down syndrome, check the thyroid, check the eye, check for hearing, check for nutrition, and also Be aware of the child's language. If the child doesn't have words to communicate, this is a child who is going to use behaviors to communicate. Now, the diagnosis of ADHD in a child with Down syndrome is similar to what you would do. So we would use rating scales. Important to use developmental age when you score your sheets. It's a DSM-5 diagnosis. The medicine that we use here, sometimes we do need to temporarily use medicine to facilitate the child to sit better, or till our interventions and our therapies fall into place. Temporarily, we might need medicines. The medicines that we use are the same ones that you would use in a neurotypical child with ADHD, but we would take comorbid conditions like the heart disease or the epilepsy into account before we choose the right drug for the child. Executive functioning is the higher function that we do. So working memory, attention, self-regulation, emotional regulation are components of this. And in children with Down syndrome, what we find is emotional control is their strength. Attention, especially auditory attention and working memory, are some areas that the child sometimes needs work on. So when we look at follow-up for our children with Down syndrome, comorbidities change over the manifestation evolves over a period of time. So we as developmental pediatricians need to follow them across from the neonatal period till adolescence. Hearing, vision needs to be screened till adolescent period. The variation that the child had, say for example, you have a child who was borderline intelligence, some issues with attention, good work in place. The strength of this child when he grows up and as an adult is that cognitively this child is good. If we have good strategies in place, cognition becomes the strength of this child to help us achieve an employment. There is a paradigm shift in our approach. We don't consider children as Down syndrome as a homogeneous group. We consider every child to be unique, and every child needs an individual plan of intervention. It's important to work early. Our critical window of opportunity, the first 3 years of life, identify the difficulty, have targeted interventions, and we will have better outcomes. When it comes to schooling, this is one of the most difficult problems for us as developmental pediatricians. How does a child, the schooling depends on the child's level of cognition. Generally, till 6 years of age, we advocate a child with Down syndrome to go in a mainstream school so that the child learns social skills, self skills, communication. After 6 years, depending on the level of cognition. So if the child is cognitively able, there are not many comorbid difficulties. This is a child borderline intelligence or above, we would integrate the child in a mainstream. However, if the cognitive difficulties are more, if the child has comorbid attention issues, autism, sensory issues, significant behavior difficulties, sometimes the child might need a special school setup. Every child's need for schooling is different. A lot more needs to be done in terms of creating awareness to integrate our children into mainstream. When we look at Down syndrome and outcome in mosaicism, there's not much of difference in terms of how the child does cognitively if the child has classical Down syndrome or mosaicism, and it's not on the percentage. So if the child has 75% mosaicism, the intellectual difficulty is more, it's not like that. So the earlier we work, and as Shruti ma'am rightly said, if we have our support groups in place, we have parents giving our other parents who are in a similar situation, giving them a positive motivation, our parents will be more aware and more positive. Schooling, as I said, depends on every child's individual profile. But if a child has basic literacy skills, getting an employment, having a vocation, a basic vocation which is supervised, becomes easier for these children. So to summarize, developmental issues, if we identify them earlier, we will identify them early if we are more aware. Start intervention early. The earlier we work, our child is going to do better. Our intervention is not to improve our cognitive score or our IQ scores. We want our child to have better adaptable skills, learning to function in society and have socially acceptable behavior, basic skills to be able to have a support vocation, because we know that upper socioeconomic class the child does better. We need to identify children with Down syndrome from the lower socioeconomic class and have intervention programs for them so that they too do well. Work in Down syndrome is not a one doctor job, it's a holistic approach. The parents need to work, the doctor needs to work, the therapists need to be in concordance, the teachers in school, the support group, everyone needs to work together, and then our child is going to achieve the best. So I'd like to end by saying, let each child blossom to his or her optimal potential. Thank you.
Excellent presentation, madam. Really, it was a very wonderful feast to listen to you. Such a difficult topic. Actually, development topic is one of the difficult topics for pediatricians, especially general pediatricians. You have made it so simple. So many facets are there to take care of a Down syndrome. And we always say, oh, Down syndrome, chala, thyroid, and our work is done. No, it is not like that. Down syndrome also requires the same type of developmental supportive care the way other children. Am I right, madam?
Yes, sir, absolutely.
Yes. There is a child, Down syndrome child, what you developmental pediatricians see and we don't see. It is a multifaceted approach or multi-targeted approach, or you can say basically what the child says. I just want to read that. Child says that my parents always tell me that I am the best, and to have me, they are truly blessed. What a wonderful actually. And to have me, they are truly blessed. I love myself and everything about me. And she also says, because there is so much more than your eyes can see. So really our eyes cannot see more than this, but you have made us more wiser so that next time when a Down syndrome patient will come to us, definitely Shruti madam and Archana madam will have different perspective to look at the patient. Now the forum is open for a question and answer session.
Yes, Dr. Abba, can I take first?
Yeah, please.
Yes. Madam, my first two questions would be pointed towards you, Archana madam, and the third question would be pointing towards Shruti madam. I have got 5 patients of mine of Down syndrome, right from ranging from age group of 6 months to 19 months. Now, the first question is 19 years old girl. She comes for follow-up regularly with me. And now since she has crossed the age of pediatrics, like adolescent, after 18 years, even after this, whenever she falls sick, her mother brings her to me. And she tells me that she gets well only if you examine her. And now I'm really in dilemma whether I should treat her, until what age I should treat her. So what should be my answer to her?
Okay, sir. I'll tell you my answer. When they come to me at 3 months, I generally keep their follow-up till 15, if they're really regular with me, till 17, after which I hand over the child. After that age, there might be some areas where I'm not the expert, so I will hand over to a physician, or in our case, if a child has behavior issues and is on medication, we would hand over the child to a psychiatrist or a psychologist who does adult counseling, so that in my heart I'm clear that I have done the best for this child.
Okay, my second question. I have got 6 months old Down syndrome child. After delivery, he had some breathing issue like the transient tachypnea pneumo. So we transferred the baby to NICU. And just because the baby was transferred to NICU, the mother went in postpartum psychosis. So even though I had revealed the diagnosis to father requested me.
Sasani sir, thoda mute karta ka? Sasani sir. Okay, thank you.
Father requested me not to reveal the diagnosis to the mother. So I did not reveal the diagnosis to mother till 4 months. And when they used to regularly come for follow-up, I used to always tell the father that I would wish to reveal the diagnosis to mother. But he said, no, wait, you reveal only when I will check. And one fine day when the baby was 6 months old, I was not there in town, and the baby was shown to some other senior pediatrician who unknowingly revealed the diagnosis in front of mother. And she got very angry why the first pediatrician did not reveal the diagnosis to me, even though I had revealed it to the father. So in this scenario, what should be our stand?
Okay, sir. Yes, this is a common condition. Maternal psychiatric issues, especially in terms of acceptance of diagnosis, is a huge problem, and we also face it. Generally, what we tend to do is when the parent comes in for the first development screen to us, and after we have seen the child, we tend to put forth the child's strengths and the weaknesses, and then explain that these weaknesses are because of this genetic diagnosis. But we also tell them about how there are some children who are really doing well. Over the last 10 years, sir, now we have a lot of children. I personally am following around 25 children who have borderline intelligence. They are in mainstream schools. They are needing only help in terms of medication and a few concessions. So if you work early, your child is going to do well. I think it's essential probably at this stage to talk to the mother psychiatrist, find out from him whether she is mentally ready to take up the diagnosis and reveal it at the earliest. Because though we do it with the good intention, for her now to handle it becomes, a lot of parents face this rejection asta, anger asta, denial asta. Acceptance जितक्या लवकर येईल ना तितकं ते काम करतात. ऍक्सेप्टन्सला वेळ गेला ना की ते क्रिटिकल इयर्स जातात. सो म्हणजे इन सच अ सिच्युएशन, इफ शी इज ऑन मेडिकेशन, we'll talk to the psychiatrist. We say that there is another stress coming her way. How early do I put it across, and how can we have some counseling sessions for her?
Thank you, madam.
Raja, can I take
Yes, sir.
that?
Sir, please, sir.
I think
Please,
simple
please.
way,
Please.
you
Yes.
may not label it as downs on the paper, but on paper you can write in code word like trisomy 21 or something like that, which
Okay.
becomes easy in letter pad. They won't say that you missed it. Then it will be justified. But on paper you put it trisomy 21. They don't understand that unless they are
Okay.
some Googlers. And
Okay.
that
Okay. No.
comes in one corner.
No. Here the scenario was we had already diagnosed the patient as down, but
Agreed.
father.
But mother
Yes.
don't know. So
Yes.
the mother, if she says or somebody else comes, you should put it, because they are reluctant to put that diagnosis. You can put it as trisomy 21 or
Yes.
something.
Yes. Okay.
That
Okay.
becomes
Okay.
easy. Yeah.
Okay.
Yeah.
Okay.
Perfect,
Sorry to
perfect.
interrupt.
Thank you. No,
Perfect,
no problem. No
Perfect,
problem.
perfect.
Abba, just last question for me. Sorry for this.
Please go ahead. Please go ahead.
Yeah. I often take meetings, yearly meetings on Downs. Today also I had meeting with all these patients, 5 patients of mine. And of these 5 patients, one patient who is 10-year-old girl, she is very sharp. Actually, her speech is not as properly developed as I had expected, but she looks as good as a normal child. And the worry of other parents is why she is looking nearly normal and our children are looking, a little subnormal. And in this situation, what should be our answer to the other parents?
Every child is different. In Down syndrome also, it's a spectrum. So प्रत्येक मूल वेगळं आहे. ज्याचं फिनोटाइप नॉर्मल दिसतंय त्याचा इंटेलिजन्स पण वेगळा असतो. So because every child is different, we don't compare our child with anyone else. Also, sir, as the child grows older, after say 10, around adolescent, receptive language, cognitive abilities थोडे plateau होतात. So that is why that follow-up at that age is also necessary. कि बाबा तो decline नाही ना होते. That we should keep a track of.
Right. Thank you. Thank you, everyone. Thank you, everyone.
Hello, madam. Hello,
Yes.
madam. Do you use separate growth chart for this patient, or we should use all this routine growth chart?
This is for Shruti, ma'am.
Following the growth. Anybody, you or Shruti madam, do you have separate growth chart for these children, or should we use routine growth chart?
There are separate growth charts available, sir, and it is recommended that we use those. Like as I said in the talk, we may continue to dismiss a short stature thinking it is short stature due to Down syndrome. But if it is faltering even on the Down syndrome chart, we know we are supposed to look for red flags, be it in terms of nutrition, thyroid, celiac, to name a few. So always recommended that we use the, although we don't have Indian Down syndrome chart, I think at least the others that are available should be used, sir.
Because obesity is also comorbidity in this patient. That's why I asked.
Yes.
I
Yeah,
think
yeah. So which is,
growth hormone treatment is conducted in Down syndrome because it can cause malignancy.
yeah, growth hormone is not indicated, sir. Yes, yes.
Unless until there is a growth hormone deficiency.
Yes, sir. Yes, sir. Otherwise, there is no indication.
Shruti madam.
Just one
Okay,
question.
okay.
Just one
Moitas.
question from my side.
Moitas.
Yeah. Is hypothyroidism of Downs is congenital, acquired, or both?
It is congenital and autoimmune. These are the common causes, sir. In the sense that, of course, because of the association of Down syndrome, they are prone to hypothyroidism. But of course, the common mistake happens that, sir, we check in the starting period, and then as the child grows up, they miss the surveillance. So it is as well as congenital.
Sasan sir, जरा unmute करना please. Sasan sir, mute
That's
करना.
the reason why we need to keep a tab on them. In fact, during the last health camp that we kept, an alert parent, astute parent, but the child had a TSH of over 300 and no complaints at all. 8-year-old girl. So it is both in nature, sir, autoimmune as well as congenital in nature, sir.
Okay. Because I was wondering, because you are recommending every 3 monthly checkup followed by 6 monthly checkup.
I didn't.
So it's something
Sir,
which
it's
comes sudden.
It's no, sir. I think that did not get clear. That was only in the initial first 2 years that thyroid checking is that frequent. If I show the chart again, that is annually later on, sir. And the reason for that is because autoimmune thyroiditis can crop up later on. Often we could get falsely reassured with a normal TSH at 2 years, and there could be an autoimmune thyroiditis coming at 8, 9, or 10 years. So, which is why it needs to be checked annually, sir.
Okay, thank you.
Sasan sir, बोला.
Archana madam, I want to share my one experience. Now the Down child is a loving wife and caring mother. Age 32. Her name is Juhi Tisde, living at Nashik. Properly go. The child, she had a 2-year-old boy kid, normal. She was delivered at my place before 32 years ago. And another child was Down syndrome. He is a farmer, age about 39. He is helping his father in farming. He don't have any partner to have a marriage. I am sharing these 2 patients with you. They have gone up to the age of 40. One, Jumika Tijar is married. She had a 2-year-old boy, and another is 42 years old. He is helping his father in farming. That I want to share to you. 2 children. Okay.
So the second one, the second example that you get is that you said, yes, good intervention support system. The first one, I would say, not so common that we would see. Current, like all other disabilities, marriage and married life is a challenge for children with disability, because it's a lot of adjustment. It is for all neurotypical also. So for definitely children who have disabilities, that is a huge challenge, and that may not be feasible for the child.
मोहिते सर, म्यूट करता सर, काहीतरी चालू आहे.
Generally, when parents ask us this question, if the child has moderate intellectual disability, we will say we want your child to achieve his or her best functional outcome, to be independent in self skills, academics as per the child's ability, support living. We will not advocate that your child will go ahead and can have marriage and normal child. That might happen in one case like the one that we were lucky to listen from you, but most of the times this sort of counseling just about intellectual disability and marriage is something that is a very sensitive topic, and gradually over the years आम्ही touch करतो ते.
Shruti ma'am has to leave actually. Only answer one question and then you can leave, ma'am. As you have already said that there is a non-invasive parental screening.
Prenatal, yes, sir.
Prenatal, okay, prenatal screening. It has been seen that there are certain countries which are following very meticulous programs of screening, almost around to the tune of around 92 to 95%. And once you get detected antenatally, most of them, almost all of them in some of the countries, they get aborted, terminated. So like Iceland and Denmark, these are the two countries where there is no Down syndrome.
Right.
So what you look into it, how you look to this scenario. So is it that over a period of time, Down syndrome babies are going to be extinct, or it is the way it has to be, screening and then termination? Just your viewpoint, as well as I would also like Archana madam also to put her viewpoint. Both of you, please.
So as a geneticist, not just for Down syndrome, but across conditions, we have been trained to follow non-directive counseling that also reflects with a lot of, be it any religion, that we follow, that you let the parent decide what he or she wants. I have seen families where they know that they have a child with Down syndrome and they have given birth to the child. I know families where they know that they have a child with Gaucher disease and they have given birth to the child. So I think that here none of us can comment based on the parents of 130 crore Indians, what will be their decision, because every human is different and every choice. At the same time, I've seen parents aborting a child for a choroid plexus cyst. So yes, the number of Down syndrome children will reduce as screening improves. Whether this is good or bad, I think it's subject to emotional debates, not practical and scientific discussions. And I think it's more about the parents to decide, sir.
Archana ma'am, your opinion.
I agree, absolutely.
Pramod, you have got any? Okay, Dr. Mahesh Sambar has one question to ask. Mahesh, please go ahead.
Wankhede sir and Abba. First of all, thanks for getting authorities of Downs.
Okay, thank you.
It was like more than excellent. It's it's very good talks from both. Just a simple thing. When you are suspecting Downs, how to examine for atlantoaxial subluxation, and it's quite common. Then what we see, a simple thing is for all Down syndrome, just they are hypotonic, they have hyperextensible joint, they achieve delayed milestone, so they walk by 2-3 years, and it's very common. But always test for deep tendon reflexes in them. Usually they have just 1+, or very well it's 2+. Anytime if we are getting 3+, 4+ DTR, it's an earlier sign that you have an atlantoaxial.
Sampath, please unmute.
You get clonus.
Sampath, please mute
It's
yourself.
like definite atlantoaxial dislocate. So always DTR we can check very regularly. It's clinically, so atlantoaxial is something which we can diagnose. Second thing, it's not so easy to get the X-rays flexion extension. The patients are not.
Mahesh, 1 second. Dr. Sasani sir, jara please mute karana. Dr. Sasani sir, please mute kara. Vishal. Sir, mute kara. थोडे डिस्टर्ब होते, बाकी काही नाही. सर आहात का तुम्ही? Okay, Mahesh, please go ahead.
Acha, but this regarding Atlanta axle, no, always see for reflexes if they are brisk, think of Atlanta axle dislocation. Second, if a walking downs, who is walking for 2-3 years, stops walking, any motor regression in Down syndrome, always think of Atlanta axle dislocation. So, kuni chaltana spastic with difficult to assess spasticity, that's fine. But if the baby stops walking or regress in motor milestone, always think for vitamin D, B12, that's fine. We will work on that. But if you have brisk reflexes, if you have motor regression, it's practically diagnostic of atlantaxial dislocation. It's beyond doubt, and this we can diagnose in our OPD. No need of any investigation. X-ray, what we say, no, it's flexion, extension, neutral. It's very difficult. Even in Panvel, when I ask for, most of the radiologists, they refuse. They kartas येत नाही, थांबतच नाही बा. For flexion, for extension. So it's not practical to get done flexion extension reliably. So if you are clinically suspecting, in that case, better to go for CT, because this is something which you can avoid something which is irreversible. If you have compression, that will be irreversible in that case. So you can avoid this. So clinically, if you are suspecting at the earliest, better to go for CT. That's second thing. So that's all. They are prone for seizures, and the prominent thing, they are prone for infantile spasms. Many of Downs, they have proper West syndrome. That so earliest, if you anyway suspecting spasms, like get on the EEG earliest. Thank you, Abba.
Okay, Mahesh, is there any particular age at which they are prone for such type of complications? And is there anything prevent? Hello.
Just one comment related to Mahesh itself. Some interesting.
Bola sir, bola.
From the PG days.
Bola sir.
15% downs have subluxation and 1% downs has dislocation. So even if the child is walking and all, he has very high potential to go into. Majority of them are having the subluxation. That's one. Secondly, flexion extension X-ray in a suspected dislocation is a very dangerous thing to do.
Exactly.
So I personally will never suggest doing that. Straight away go for a CT or MR when you're suspecting that. It's very dangerous. He may be in subluxation and he may potentiate or kind of accentuate into dislocation. And once dislocated quadriplegic, you are going to add major misery. When you suspect that, as Mahesh rightly said, hypertonia and hyperreflexia in a Downs is a clear suspect. Straight away go for CT or MRI. Don't try X-ray flexion extension. That's very dangerous thing to do. Yeah.
Mohite sir. Hello. Yeah. Pertaining to your suggestion and this question, how far it is risky to do Moros in case of atlantoaxial subluxation patients in Downs?
When you are suspecting a Downs, I don't think Moros will really cause much issues,
because Moros is absent in this child because of hypotonia.
Not really. Moros won't be absent. As Mahesh said, the reflexes are there. Maybe grade 1 and grade 2, or maybe DTR 1 or 2, and they are hypotonic. But Moros still will be seen. It's not a weakness that is there.
Can you go for testing? Can you go for testing?
Make Moros there. We say that they have a good power, but still that phase, no, it's not that prominent to have that brisk Moros. Yes.
Okay, Archana madam, please. Archana madam, please.
Just like all the developmental milestones are delayed, the Moros will integrate slightly later. So if we say that our Moros in a neurotypical child will integrate by 3 to 4 months, in our child with Down syndrome, it will integrate at a slightly later age. It's not that it will be diminished or exaggerated. It's just the integration, the developmental age at which it will happen.
Jay, please go ahead.
Yeah. First, my compliments for Raigad IAP. There's an excellent discussion on Down syndrome, because we see a group of patients, and Pahel, I want that WhatsApp number so that I can give to my all parents. That is first thing. I have a question. Suppose I suspect Down syndrome. There are obvious clinical features of dysmorphism and other thing. Whether I should prove it chromosome studies, which is important, so that I can prognosticate, give the confirm head downstairs ahe, that is first thing. And second, suppose that is the first child of the parents, whether they can plan second child, and whether that chromosomal studies or genetic mapping of the child itself gives a prognostic, what is the chance of recurrence in the later pregnancy. Because once there is a Down syndrome may be delivered, the whole khandan, I can say, there is a totally absolutely behind that child. And my observation, mothers takes care of that child more than father, because father is usually out for his job and other things. Yes, he's involved in the treatment, but for out of 24 hours, he's almost 10 12 hours out of his house, and mother is a major caretaker of the child. So please, my compliments again for this beautiful session, and give some inputs for this also.
ओके सर, श्रुती मॅम असल्या तर त्या
नाही
बोलतील.
नाही मॅडम ऑलरेडी त्यांना काम होतं.
बरोबर. See, when we clinically suspect Down syndrome, always do a genetic test. Why? Because depending on the type of the Downs, our recurrence for the next child, it is important. Like 95% we said have 3 chromosome 21. In these children, the risk in the next pregnancy is lower. If you have a child who has a Robertsonian translocation, there is an unbalanced translocation or an extra bit which behaves like chromosome number 21. This the child has got from the parent. The parent has a balanced translocation, so the parent is asymptomatic, but they are a carrier of this. In this case, in the second pregnancy, we would need to do antenatal testing and amniocentesis to check. In case of mosaicism also, it's the recurrence is higher. So if we know the type, we can help them, not in prognostication, because if you see all these 3 types, the children will do similar.
Right.
Every child is different, but the type of Down syndrome doesn't change the way the child manifests. Prognostication la nahi, but second pregnancy, genetic counseling la, it's very important.
Right. Which is the best one? Coronary biopsy is the best, or amniocentesis is the best to diagnose in antenatal?
ह्याच्यात मी स्पेशलिस्ट नाही, ते जेनेटिसिस्टच, पण आय विल से amniocentesis करतात and Coriolanus biopsy. I'm not a specialist in this. Shruti ma'am is. Our job is to refer.
I think the recurrence of Down syndrome in the same family is almost in the tune of around 1%, I think.
If it is trisomy 21, recurrence is very low. The translocation मध्ये high.
Because
the parents will be always interested.
Yeah, definitely. But chances would be definitely lower on the card. It is not
Right.
the first down, so second will be also downs.
Right. They will ask, when you label as a metabolic or genetic conditions, they will ask if whether it is a possible recurrence, and we have as a consultant, we have to refer them to the proper geneticist or other thing. It is very important.
Perfect. Mohita sir, please go ahead.
Translocation has, to my knowledge, has a recurrence rate of almost 25 to 50%. And
Yes.
non-disjunction, which Dr. Madam said, that has 1% chance. So general population, I suppose, it's 1 in 400, almost like hypothyroidism. That, no, I think it's 1 in 1,000. What is the
1 in 800.
1 in
1 in
1,000.
800. It's almost like
1,000, yeah.
hypothyroidism. It's almost like hypothyroidism. But same in case of trisomy, that's non-disjunction, it increases by 10 times. This becomes 10 times higher. That becomes approximately 1 in 80 to 1 in 100. And translocation, as Dr. Kadam said, it's it's like autosomal dominant. So it will be almost 50%. But in either case, you don't want to take that 1 in 80% chance also. For that matter, even the first pregnancy nowadays is very aggressively screened whenever it's affluent class. So you're doing the nuchal thickness right at 12th week, and if there is any doubt, you check the scoring incidence rate, and that is so, then you will be doing the triple marker and quadruple marker in the 16th week itself. So if you have adequate window to go for the termination. So that's how they will do. In fact, nowadays they do in the first pregnancy itself. Forget the second pregnancy. People don't want to take chance in the first pregnancy also. So that's how you said about the Scandinavian countries. It's a kind of a complete newborn screening, or for that matter, a fetal screening. They do right in the first baby itself. So they could reduce the trial incidence.
Okay, I think only last 2 minutes. If anybody has to have any comments, Jay is raising the hand.
Hand is already raised. तसाच आहे तो काढलाच नाही मी.
Okay, no problem. I think I'll ask Dr. Pramod. Okay, Mahesh, please go ahead.
Just
Only I want please take Dr. Wankhede sir. Archana madam, त्यांना exact कसं monitoring करायचंय. Already you have told everything, but suppose you post it on the group, so we will keep with that patient, or we can give to the patient so that we can follow that very better way.
जय उद्या टाकू दे, कारण आज रात्री टाकलं तर आपण उद्यापर्यंत विसरणार. उद्या टाकू दे.
हो चालेल ना.
Okay.
But I can say it was an excellent discussion. फार छान एकदम.
Mahesh, please go ahead. You have raised the hand.
No, just 4 days back, आता ह्या आठवड्यात I have seen which was phenotypically Down syndrome. Very silly question. Can Down syndrome have normal karyotype?
No,
Actually,
no.
Shruti madam has left, but maybe still Archana madam if you can.
I will say no. No.
It's a genetic disorder. How a Down will have chromosomal anomaly with
No,
not having. बोला.
Mosaic
That can be
असेल.
mosaic.
बोला sir.
That can be mosaic.
But still it is abnormal, no? But still it is abnormal, no?
See,
No,
mosaic
agreed.
मध्ये
Then a certain set of cells may have
Oh,
normal.
but still it is abnormal.
पण
If they are reported as normal, then be careful about that.
Yeah.
another thing,
Mosaic.
either phenotypically child is normal, absolute no dysmorphic features and have that chromosome, whether it is possible.
Mosaic.
clinically
बाबाची
down.
care. अरे राजाने के सांगितलं ऑलरेडी तुला. राजाने के सांगितलं तुला ऑलरेडी.
हो.
उसका बच्चा नॉर्मल क्यों, मेरा क्यों abnormal?
Pramod, you have got any comment to make? We want to conclude the session.
Yes, Abha. This is a very excellent session. When you suggested the name of Archana madam and Shruti madam to me, definitely both are the stalwarts, and session has to be excellent. Along with a knowledgeable person like Abha, comparing this session. So everything was excellent, or excellence rather. So thank you very much, Abha. Thank you to both experts for your very knowledgeable approach. And thank you to all my colleagues, they have attended it. Thank you. Thank you.
Yeah. In introduction, actually, one line I missed to tell you about Archana madam. Archana madam has her own private clinic set up behind at Deccan, basically, Hope and Health Clinic, where she practices with her spouse, husband, basically Dr. Sandeep Kanam sir, who is very well known to IAP Raigad. So that introduction I have remembered. Thank you, Archana madam, and Shruti madam is not there, but thank you, Shruti madam, also for being with us, and excellent inputs from you all, both of you. Literally, it's a topic which is so simple, basically simple enough for them to identify a child, but there's so many facets: developmental delay, motor delay, language delay, behavioral issues. So many things are there, which really, honestly, I will tell you, we pediatricians, at least at my level, I can tell you, we have never taken care of that. But henceforth, any Down syndrome comes to us, first we will say that how developmentally is normal, because we want to make him more sustainable rather than more self-sufficient. So thank you very much. Over to Dr. Dhananjay for vote of thanks.
Thank you very much, sir. Today is World Down Syndrome Day, and on this occasion, we had this wonderful session. We are really fortunate to have two stalwart speakers today. On behalf of IAP Raigad, I would like to thank Dr. Archana madam and Dr. Shruti madam for accepting our invitation and discussing this topic in depth and answering all the queries patiently. Thank you, madam. I would like to thank Dr. Abha sir for wonderful moderation and getting these two authorities in this Down syndrome field on the virtual dais for IAP Raigad. Thank you very much, sir. I would like to thank Dr. Wankhede sir, President IAP Raigad, for arranging this session. Sincere thanks to Dr. Mahesh Mohite sir, Dr. Sastane sir, Dr. Chandorkar sir, Dr. Bhandarkar sir for their valuable inputs. Also, Dr. Mahesh Sambare sir for sharing his experiences. And sincere thanks to all the other delegates for attending this session. Finally, sincere thanks to Dr. Vishal sir for making the Zoom platform available for this wonderful session. Thank you, one and all. Thank you very much.
Thank you. Thank
Thank
you.
you. Thank you.
Good night.
Thanks to
Please
Neha.
everybody join on Friday
Yes,
for
yes.
MyAP.
Thanks
Dr.
to
Praveen
Neha.
Gaikwad is there for his MyAP Katta.
Okay. Sure.
Hello, hello, Dhananjay.
Yes, sir.
Hello,
Yes, yes,
Dhananjay.
sir.
There is one
Yes.
announcement that tomorrow also we are having the session at the same time, 9:30, on teenagers by Dr. Kiran Vaswani ma'am.
Yes. Yes, sir.
Please be on board tomorrow also.
Okay.
I request you all.
Okay.
And another thing, thank you for Neha and Abba Sahib for making flyer excellent flyer. Thank you very much.
Thank you. Thank you. Good night. Good night. Good night.